Okay, great. Today, we're going to study from the AAPC book. Okay, let me take a peek at that. And this is a 2019 version. Me and my student Twee, say hi, Twee. Hi. Okay, we're going through this today. So it has a lot of chapters. Okay, so we're going to go through chapter 1, which says the business of medicine. So I'm going to read this. I want you to pay attention. And every time I video record, I'm going to upload this on YouTube in hopes that y'all can hear me. If you cannot hear me through your phone device, you need to let me know. Are you using an Apple phone or a smartphone? I'm a smartphone user. So I hear my videos just fine through smartphone. If you have an iPhone, I don't know what to tell you. I'm not an Apple user. That's just not me. I'm sorry. Okay, great. So coding as a profession, each time an individual receives health care, a record is maintained of the resulting observations, medical or surgical interventions, diagnostic tests and studies, and treatment outcomes. Coding is the process of numeric and alphanumeric codes. There are separate code sets in described diagnosis, medical and surgical services, procedures, and supplies. These code sets serve as a common language to ease data collection. So, for example, to track disease, to evaluate the quality of care, and to determine its costs and reimbursements. Proper code assignment is determined by both the content documentation in the medical record and by the unique rules that govern each code set in its instance. Coding rules are also may vary upon depending on who pays for the patient care, such as self-pay or health insurance. Coding is typically performed by either the physician or a coder. When a physician performs the coding, the coder may take on the role of an auditor to verify the documentation that supports the code the physician selected. In some practices, the coder will receive a medical record, code the services based on what is documented in the notes. So let me take a pause break on that for a minute and write on the board what that means in physician notes. This is on an outpatient basis. Okay, so when, okay, let me put that back in the bucket. Okay, physician coding. I hope y'all can see that. Okay, so physician coding. Physician coding takes place, and I'm gonna write with black, give me some more markers. Takes place in a doctor's office. Only in a doctor's office will they do SOAP notes. Okay? SOAP. This is the format which is known as SOAP notes. In other words, back in the day, we used to call it progress notes. Progress notes is the same as SOAP notes. Okay, so if a doctor, is pretty much old school, he's 50 and above, he's talking about, if he says, Twee, bring me the progress note on that person out of their chart, or print me the progress note out of that patient's chart. He's asking for the SOAP note. If he says, print me the SOAP notes out of that patient's charts, he's asking for the progress notes. They're one and the same. Okay, so SOAP. SOAP means subjective, objective, assessment, and plan. Okay, this right here in subjective is the conversation between the nurse and the patient. Objective is the conversation between the patient and the doctor. This right here in assessment is where the diagnosis code and the procedure code goes. Remember, if you've taken med terminology and you've studied medical abbreviations, and I'll move back a minute, then you would know DX means diagnosis code. P as in po boy or something like that, purple, is PX means procedure. Okay, so you need to understand that this is only done in a physician's office. This is not a format to use in hospital coding. That's a whole different genre of stuff, okay, of how that's being done. All right, so going back to the reading here, coding, and I'm going to read this again, is typically performed by either the physician or a coder. When the physician performs the coding, the coder may take on the role of auditor. That means, so sometimes a doctor may have what you call a cheat sheet. And there's a cheat sheet. I'm just pulling up something by example. This is not a real cheat sheet, but I just want to give you an idea. A cheat sheet may have a list of codes that he commonly sees all day, every day. List of diagnosis codes that he treats for all day, every day. And then if he doesn't, then they have a software that he can put in the name and it'll give him the code. So he would write down, let's say for example, right here, and I'm gonna back up a bit. DX. So say like the diagnosis is R51.3. Okay? And the procedure code PX is 99203. Okay? So he may put that there himself. That's fine. Some doctors want to be independent or self-sufficient in their knowledge of coding. That is great. They don't know a whole lot, but they know that much. Okay? Now, your job as a coder before it gets to the biller, or you doing both, is to make sure that his documentation is correct. Is the documentation correct according to what he complained about to the nurse, his onset? Why is he there that day? Is it the same of why he told the doctor he's there, and now the doctor is going to do a review of systems? Review of systems is a review of how many systems of the body are there? If you took medical terminology, anatomy, physiology, there's 11 systems of the body. Okay, it's okay. We're reviewing. So it's 11 systems of the body. Okay, so if you come in with, I have a sinus headache, my nose is runny, and my chest is congested, then what you're doing is you're going to check for the head, which is the nervous system, the head, headaches, migraines, whatever. You may check for the respiratory system because he complains that he's stuffy. Okay, then you're going to check for the I forgot the other name of the system of the body that deals with the ears and the eyes, the sinuses and all like that. You're going to check that. So the doctor already know based on what he told the nurse, based on what the patient told the nurse, based on what the patient is telling the doctor, he knows to check 3 out of 11 systems of the body to verify, this person really has this issue. Oh, I looked up your nose. It's red. You got an infection. Oh, you got some phlegm. I could hear the rattling sound in your chest. Sounds like you got bronchitis. Something to that effect. Does that make sense? Okay, super fantastic. So you, the coder, have to make sure that the codes he used match the documentation of what was put down by the nurse and what's been put down by the doctor. Make sure it's all correct. If the doctor is going to do labs, such as a chest x-ray to see how congested he is, to see labs to see about his blood work, his CBC, his white blood cells, his red blood cells, see if it's low or something like that. You, the coder, have to make sure, is this deemable necessary for him to do these labs for us to use these codes? Mm-hmm. So everything has to line up. And so once it all lines up, then the coding is good to go. It's good to go to the what? Next stage. The next stage is what? Billing. When the biller gets ready to set everything up to bill for the day, then it's going through the clearinghouse. From the clearinghouse to the insurance company. But if it don't go through the clearinghouse, you're going to get a kickback. That kickback is going to tell you something's wrong with this claim, and I ain't gonna send it to Medicare, or I ain't gonna send it to any other commercial insurance because it's the wrong ID, it's the wrong date of service, not date of service, the wrong date of birth, something to that effect. Okay. All right. If the medical record is inaccurate or incomplete, it would not translate properly to the language of codes. The coder must evaluate the medical record for completeness and accuracy and communicate regularly with physicians and other healthcare professionals to clarify diagnosis or to obtain additional patient information. When you're the coder, you're the one that's going to say yes, no, yes, no. Do you understand that? Okay? All right. And you want to be that person. Don't be afraid to tell your doctor, okay, we're missing some information. Or better yet, go to the nurses first, because sometimes the nurses are the right hand of the doctor, and the doctor may not be in that kind of mindset to be friendly in communication with you. Okay? So if you talk to the nurse, and the nurses sometimes, but they're a little bit more better, then you can get what you need based on the nurse, because they're the clinical professionals. We as coders and billers and front desk folk and collection, we are not clinical staff. We don't touch on patients. We don't make those determinations about their results and their sicknesses and their illnesses. That's for the nurse and the doctor, the physician assistant, or the nurse practitioner, or anyone in the clinical arena that touch and deal with patients. Your job is administration. Your job is money and paper. That's all you do. Money and paper. Money and paper. That's it. Okay? All right. If the medical record is inaccurate or incomplete, it will not translate the language of codes. The coder must evaluate the medical record for completeness and accuracy and communicate regularly with physicians and other healthcare professionals to clarify diagnosis or to obtain additional patient information. Outpatient coding focuses on physicians' professional services and outpatient facility coding. So let's talk about that for a minute. Okay. I'm sorry, Tweet. I'm just sitting on them stuff. I was going to offer my jacket in case you get cold. So I'll just sit it right here. How about that? Okay, so okay. So let's erase this. All right. Now it says right here that coding focuses on physicianal professional services. Okay, so on physician professional services, as I'm lecturing and reading, I'm trying to give it to you in colorful words and lecture so you can understand the whole gamut of what's going on. When it's done in the office, this is the place of service. POS is place of service. In that CPT book, show them the CPT book, Tweet. There you go. In the CPT book, in the first 5 pages, thank you, Tweet. In the first 5 pages, it's going to tell you the place of service codes. Okay? I'm going to tell you some of the most popular ones. 11, 22, 12 for home health. Maybe 03, I don't forget. I think 03 is patient office, but maybe in a rural area. These are some of the place of service codes that needs to be on the CMS 1500 form. And we know back in the day, a CMS 1500 form is known as the HCFA 1500. Okay, let me kind of bent that up a bit. Okay, is known as the HCFA 1500. Okay, now you have type of service. Type of service in the doctor's office, it's going to tell you, and I don't think it's in the CPT procedure books. That's something you have to Google. There's a list of them separately in the online. And then you come on over and you have the procedure codes. Now, let me explain to you the difference. Procedure codes tell what the doctor did. Okay? What the doctor did. Procedure codes are normally explained on a professional level. So let's just say, for example, if a doctor performs surgery at Memorial Hermann, okay, he performed surgery at Memorial Hermann, he can't charge for his handiwork through Memorial Hermann. That handiwork has to be charged at his office. Okay, he does work out of Memorial Hermann, but his office where he see patients for follow-up, new patients, follow-up from the hospital is done at his medical practice. Okay, so here's another popular place of service. 21. 21 means inpatient. Back this up a bit. 21 means inpatient. So say, for instance, the type of service is hospital visit. He saw the patient in the hospital. How is that going to be known? The coders at the hospital is going to get in touch or send some sort of data graphic information to the coders at the physician offices. So you're probably wondering, how is that happening? I'm glad you asked. Because the hospital communicates with the doctor's office. You have an inpatient coder, and you have the outpatient coder. Now, these require different certification. This is CPC-H. CPC, Certified Professional Coder for a hospital. That's another certification that you have to go for. Okay, it's not hard. Once you pass the first one, you should pass the second one. Outpatient coder. Forgot to write that word. Outpatient coder are your ones with the CPC. And sometimes they have CPCP. That means Certified Professional Coder Physician Office. They only do work for the physician office. Now, sometimes you can have a person that has the regular CPC and they could pretty much get away with working in all aspects. You can. You can be an inpatient or acute care coder. Inpatient means acute care. You can do that as well. And you can also do outpatient coding. So now, in the hospital, so the inpatient coder is going to communicate with the outpatient coder to let them know. Can y'all see that? I don't think y'all can see that. Okay, there it is. It's going to communicate with the outpatient coder to let them know what did the doctor do for the patient while they were in the room. Okay, well, the procedure code is 99, for example, 241. And we already know, looking at some of the variables, some of the keys, maybe 2 out of the 3 or 3 out of the 3 is going to tell you the physician spent 10 to 15 minutes with the patient. So the first code is a level 1. Remember, any code that has a 1 at the end means level 1. If this was a 99242, that means it's a level 2. If it was a 99243, then that means it's a level what? 3. Very good. So the 99241 is your typical inpatient procedure code. And the place of service is 21. Do you see that? So on the CMS 1500 page, it's going to look somewhat like this. Place of service was done in the hospital. Type of service was hospital care. Procedure code, I should write that aligned to this. 99241. You see how that worked? The doctor cannot charge through the hospital to say, I got to charge for my handiwork. His handiwork is whatever surgery, whatever he did to see about you, whatever surgery he did in the hospital, it has to be charged on the CMS 1500 form. Now, what is the UB04 for? Or the UB92? We used to call it UB92, Universal Bill 92, but it's been updated as the UB04. The UB04, right up here. The UB04 is for inpatient acute. Acute means inpatient. So if someone says, what type of coder are you? Are you an acute care coder? Or are you an outpatient coder? If you say I'm an acute care coder, that means you're telling them you what? You code what?
For the hospital.
For the hospital. You code inpatient for the hospital. Okay, so the UB04, they charge for surgery room expense. Okay, it costs money to use that ice cold surgery room. It costs money to use their equipment. It costs money for them to put you in the recovery area. They got to charge for that. They got to charge for room and board. They got to know how long, when did you check in? And what time did you check out? Sometimes checkout stops at 12. If it goes all the way to 12 the next day, that means from 12 the next day on back, they're going to start charging you for that. If you're there till 2 o'clock noon, they're going to charge you 2 o'clock noon up until the next day because you are beyond the 12 o'clock limit. Does that make sense? Mm-hmm. They consider everything from 12 a.m. to 12 p.m. That's a 24-hour time work. Does everybody understand that? Okay? So if they release you from the hospital at 5 this evening, they charge you for an extra day. So you might as well just go and say, give me some dinner before I leave. Give me some snacks before I leave. Yeah, I take advantage of it. I sure do. Okay. 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 So let's just say, now let me turn this around. Okay, yeah, this is good. Let me turn this around over here. Now, let's suppose this patient was admitted September 3rd, 2019 to also September 3rd. Again, we're dealing with the CMS 1500 form. Okay? Now, he also saw the patient on Labor Day, and they don't charge extra for Labor Day because it's a holiday. It is what it is that day. There is no overtime, overage, or anything like that. So get that out your head. So if you're a doctor looking at this, get that out your head. If you're a patient looking at this, stop being afraid. They don't do that. That's against the law. Okay. So 9/4/2019 to 9/4/2019, same thing, except right here, same thing, same thing, same thing, same thing. And let's suppose the patient had a little bit of complication. And the doctor has to do some tests. He's going to come see him, and then he's going to come right back and see him a little bit later on that day. So he's spending just about a good hour on that floor before he can go back to his office to see his patients at the office. Mm-hmm. So now, instead of it not being 992, you know how doctors come into a room and they see you and they say, how you doing? You doing okay? Okay, great. Did you have breakfast? Oh, you about to have breakfast. Okay, well, your chart says this, and your lab say this, your vital signs say this, you're doing great. Okay, well, I'm going to come back and see how you're doing later on. That right there is 99241. You know how much that is? That's $200 and $250. In 5 to 10 minutes. Show me. Now, you telling the doctor you having complications. Maybe you having a little fever. Maybe you develop some sort of nosocomial infection, and you're getting a fever, and you're getting some sort of symptoms that's telling them it's either something in the hospital, in the air of the hospital, or something you've done, or some environmental stuff that's been around you, like people that like to come visit you and stuff like that. Okay, so he's got to do some labs, and he's got to kind of stick around and see the labs. He's going to do some labs. Stat. Stat means what? I need these labs done stat.
Quickly.
Quickly. I need these labs done immediately. Okay? Now, he's messing around. So now this doctor is gonna charge you $650 for an hour. And he's got to call his nurse. He's got to call the front desk people and say, hey, tell my 1 o'clock patients I'm gonna be 30 minutes late. That happens. Sometimes complication stuff rise up at the doctor's office. If you're going to be a front desk personnel, you got to know how to accommodate the patients in the waiting room. You're going to be anywhere in the front. You're going to be a practice manager. You got to know how to accommodate the patients and deal with the attitude of your employees. Sorry, it comes with the territory. Nothing is ever easy. The more money you make, the more responsibilities you have. It depends on if it's a headache to you, or it depends on if it's fun to you and you can handle the stress. It depends on if the stress is good for you or if the stress is healthy. I'm not going to say great, I'm saying healthy. Why? Because some folks, if you're passionate about what you do, then it's not stressful. It's just like, wow, I'm just doing so much. I haven't had time to eat a Snickers. By the way, I left the snacks in the car. Okay. Anyway. So, do y'all understand that? This is done at the biller's hands. So from the coder, this is what the biller does. But the coder makes sure that everything is documented and aligned correctly. So when the biller gets it, all they do is sit there and press a little pretty little button and it goes. But now that's not all the work that the biller does, because if it kicks back, they too got to audit and investigate why did it kick back. Oh, front desk didn't put in the patient information correctly. The coder, instead of it being 9921, the coder put in, or the doctor put in 99240. The system doesn't recognize 99240. So now you, the builder, are going to have to do some auditing on your end backwards. Okay? So it's not just cute trying to be a builder. Okay? It's not a cute job. It's a fun job. I like it. Been doing it since I was 17. Okay, come right along this way. Outpatient coding focuses on physician professional services. Outpatient facility coding. Outpatient coders will focus on CPT, HCPCS Level 2, and ICD-10-CM. Okay, so let's talk about each one of those. I'm going to go ahead and erase this. Are y'all okay with that? Are you okay with that? Let's make sure y'all got everything. Y'all see everything on here? Okay, very good. So I'm going to erase this. CPT, ICD, 10-CM, HCPCS, ICD, 10-PCS. Okay, so let's talk about these things. Okay, CPT is mostly used in a physician office. And some outpatient facilities. And we're going to talk about that a little bit later. Okay, ICD-10, and again, this also tells about the procedure codes. This tells about the procedure codes. ICD-10-CM tells about the diagnosis code. Okay, this can also be done inpatient and outpatient. Okay, that's an and sign. Inpatient and outpatient. I know that looks kind of light, and I'm going to get me some more markers to write with, but I hope y'all can see that. Hicks picks. Hicks picks are, now this is kind of run out on me. Hicks picks are your coding books, your procedure coding books for DMEs. What does DME stand for? Durable medical equipment. That's what it means. Durable medical equipment. Okay. So in case, and I don't have a book on me right now, I left that in my van. But if you're trying to find a code for a wheelchair, there's different kinds of wheelchairs. Oh, bless you. Thank you, Tweet. Okay, so here it is. Hicks Pick Level 2 book. And all of these have different codes. You got it. All of these have different codes according to what's needed. Now, if you're going to work in the home health industry, if you're going to do billing for home health, having oxygen tanks delivered to homes, having wheelchairs delivered to homes, different feedings like ensure, what if the person has had some sort of gastric resection type surgery, and they have to use a colostomy bag. They can't defecate on their own. They have to defecate through a bag, and they have to keep it kind of hidden on their body. Different things like that. If they're having work done on dialysis, things like that, and they're using the equipment, this is what this is for. Okay, not to tell how many minutes a patient or the doctor spent. Not for casting, well, maybe for casting for the materials or sling or crutches. Yes, you can use that book for that reason. But anything else that's medical is going to come out the CPT book. Okay. Now, some doctor's offices, if you family practice, if you're a pediatric office, then if they're the ones that kind of treat for strains, sprains, maybe give a person crutches, maybe a walker, what you call those scooter things when somebody done had surgery on their foot, they kind of scoot around. Looks like fun, but I'm sure it's painful. This is what this for. So in some physician offices, they will have a CPT and a Hicks Picks book. You have the tools, you just need to know what to do with them, and this is what they are for. Okay? Now, let me also show you what is an ICD-10 book is for. This ICD-10 book is very organized, and it's organized a little different from the regular ICD-10 CM book that's from the World Health Organization. So AAPC has structured and restructured their book to accommodate their organization style, learning style, coding style, but yet it is the same thing. Okay, it's just a little different. So beware that if you're going to borrow somebody's book, and if it's an AAPC book, you need to rehearse how to use that book because it's a little different than your regular ICD-10 book that's made by the World Health Organization. They look somewhat the same. The only difference is this is AMA. Okay, but this is done by it just this come through AAPC, right? Mm-hmm. Yeah, this came through AAPC. So American Medical Association. Again, they work with AAPC. You're going to have to study how to use that book because remember, when you get ready to do the coding test, it's time. You can't just wait till the last minute and say, I don't know how to use this book. How do you? Nope. You need to look at the difference between this book and the one that's made by who? World Health Organization. And you need to study the differences of how they're used. Okay? They look somewhat the same, but make sure you open it up because sometimes they're not. If you're going to borrow somebody's book, make sure you know what you are borrowing and how to use that tool. Okay, very good. Thank you, Tweet. Okay. So, we didn't finish. And then the ICD-10 PCS, This is procedure code done for inpatient surgical procedures. Okay? And these have like 2 digits. Remember, this is only utilized for acute care. This is only utilized for acute care. And what I mean by acute care, what do I mean by that?
The hospital.
Hospital. It means inpatient. Okay? So you don't ever use this book in a doctor's office. If somebody told you that you use this book in a doctor's office, call me. 281-723-4762. If they tell you to use this for a diagnosis code book, call me so I can charge them per hour to tell them you are wrong. And I need to help come educate you on how to properly use the books and what each one are for. Okay? Okay. Because that some folks like to kind of mess with other folks' minds, really. Mm-hmm. Yeah. And if you don't know any better and you green to the game, they'll have you believe in anything. Mm-hmm. I'm telling you right here, live and in living color on TV, well, video rather, that ain't the truth. And that's a lie from the pit of hell. Tell them I said that. I mean that. Okay. All right, so let's go back to the reading here. My allergies in my left eye. God, I hate that. Okay. Hospital inpatient coding forces on a different subset of skills where coders will work on ICD-10-CM and ICD-10-PCS. I just got through talking about that. Outpatient coding, inpatient coding. If you're an inpatient coder, you're going to use both of these books. If you're strictly inpatient. If you're an outpatient coder, you're going to only use ICD-10-CM. Okay? The coders will also assign medical severity diagnosis related groups, okay? DRGs. DRGs are like, I need to write an example, but I'll explain it first. Let me get some water, hold on. Oh, that's good. Okay. DRGs, diagnosis related groupings, are groupings that if there's a huge bulk charge of common diseases, common illnesses. I'm going to tell you what some common illnesses are. Hold on. Move this out the way. And this is how we're going to study. We're going to study chapter by chapter. Chapter by chapter. So when I finish lecturing chapter 1, I want you to go back over this week and review chapter 1 and do the review test and see how you do. Then compare the answer keys. Okay? All right. Now, let's see if this will work. Okay, so DRGs. Can y'all see that on the video? Oh, that showed up a whole lot better on the video. You can see that, huh? I sure hope that shows on the video. Okay. All right. So, what are some common diseases that a high population of folks may have? And I'm not talking about race. I'm not talking about gender. I'm talking about, doesn't matter what age.
HIV.
So, huh?
HIV.
HIV. That's one. Name another. Mm-hmm. Diabetes. Mm-hmm. Diabetes is a common one. Okay. Stroke.
Cholesterol.
Okay, that's a symptom. That's a symptom too. Heart issue. Okay. Congestive heart failure. Okay. These are common illnesses with huge populations. Huge populations. Okay? So it doesn't matter what race, what age, um, the person's or the patient is. What matters is, oh my goodness, there's a lot of folks from Houston, Texas that let's just say for example. I'm just saying for example. I'm getting my doctorate starting next year in School of Public Health. So don't hold me to it. I'm just saying for example. Okay. Um, let's say Houston has 15 million folks affected with HIV. Diabetes have 25 million folks. This is in Houston. No, no, let's say Texas. We're going to say more bigger than the city. Let's just say throughout the state of Texas. Doesn't matter which region. Throughout the whole state of Texas. We went into the diagnosis database, and all the diagnosis database gives us our readings. Now, you probably wonder, how do we acquire such information? I'm glad you asked. Every time a patient comes in to see the doctor and a code is put in the electronic health record, those diagnoses are drafted into a database. Okay, that's how World Health Organization can update their ICD-10 books every year. That's how American Medical Association for AAPC update their books. They go on statistics. We have to have diagnosis codes and procedure codes to give us statistical facts on what's going on in different parts of the world, what's going on in the whole state of Texas. Then it can also be broken down further to say this is so many in East Texas, east side of Texas versus the west side of Texas. This is so much in the north state of Texas versus the southern part. And Houston is in the southern part of Texas. Does everybody understand that? Everything has its regions and reasons for reason. Okay? Because we need to know how does a disease begin? How can we eradicate that? How no, not yet. Please don't shut down, not yet. Okay. We need to understand where is it coming from? How can we eradicate the disease? And is this going to be a trend? Because some things come back as a trend. Just like with measles. Measles for a short little while, 2017, 2018, months as well, started coming back. They were huge in the early 1900s or late 1900s. They were huge, and then vaccines were created to bring down the sickness in the population. So now you have some parents. I'm not down in parents. I'm just saying facts. Go against vaccinations for their kids because they figure that vaccination has a link to autism. I don't know if that's true. I don't know if that's false. I just go based on what the readings are and what's put into the journals. I go by that. And so we have to acquire such information, and it's known by aggregating. So if we want to know by aggregate, we're going to put in all the diagnosis codes that deal with diabetes. Does that make sense? That aggregate is going to tell us here are all the patients that deal with diabetes, period. It could be diabetes 1, it could be diabetes 2. It doesn't matter. Now, if you want to aggregate and specify your aggregate and say how many patients have diabetes 1, type 1, then it'll break it down further. Everything is done by aggregates. Aggregates are done according to a requested subject. Okay, that's what aggregates are. Does that make sense? Because you need to know what aggregates are when you read into your test. Okay? All right. So, strokes, sometimes you may have, I don't know, maybe 13 million folks in the state of Texas. And congestive heart failure. You know we like that Texas chili, that barbecue. There's a lot of us. So we kind of neck and neck with the diabetes. Why is that? Because a lot of times, whatever goes on in the pancreas, in the blood for diabetes, it also affects or has a propensity to affect the heart, cause cholesterol issues, blockages, and such. So these two play a hand. Now, instead of having, and I'm just saying, for example, I don't know. I'm just guessing. I don't know. So let's say the diagnosis code is A12.3. Okay? And diabetes is B149. Strokes are C15.6. Congestive heart failure is D231. Okay? Now, instead of this being billed all the time and taxes through CMS, through Medicare, we're going to say Medicare, and some commercial insurances that contract to get their cost on a Medicare level. CMS are the ones that give the guidelines and the payment guidelines, the RBRVS, of how certain codes need to be paid. They also do the same thing of how some DRGs are to be paid. Okay? They are the mama of everything. Okay?
CMS.
Yes. Okay, so say like every time a patient is billed, let's suppose this is, all these are going to be based on, no, that's not 3 days, let's say 4 days. A 4-day hospital stay, okay? A 4-day hospital stay may charge $20K. For this, no, that's more expensive. Sometimes they're a little bit more expensive. So $40K, okay? Diabetes may charge $30K. Strokes may charge $32K, and I'm talking about thousands. Congestive heart failure is $40K. I mean, oh my God. Okay? To cheapen the cost of what insurance companies pay, or to cheapen the cost of what Medicare pays, the DRG, and let me write it over here. The DRG is going to pay out at a discount. They're going to pay out at a discounted rate. And they have what we go by as weight. So the DRG weight for this may be 4.36. The DRG weight for this may be 3.6. The DRG weight for this may be 4.2. The DRG for this may be 5.6. They are weighted. So that way, every time a patient goes in, an HIV patient, let's say for example, goes into the hospital, they have a 4-day stay. They get better, they told what to do, they give them their instructions, they're giving their medication. They've done all the right things to get discharged. It is going to cost Medicare or a commercial insurance, and I'm going to tell you, commercial insurance are your Aetna, Cigna, United Health, Molina, Blue Cross Blue Shield, others alike. Those are commercial. CMS, or your governmental insurance, is Medicare, Medicaid, Champus, and
Amerigroup.
No, not Amerigroup, but TRICARE.
TRICARE.
Your military insurances.
Yes.
Those are your governmental insurance, okay? Now, every time this person, let's just say, for example, has Aetna, and he goes into the hospital, and Aetna is charged $40,000. And if there's no DRG for the $40,000 set up after a certain period of time, Aetna may pay out $15K. Now you're probably saying $15K, that's all they gonna pay? Well, what happened to the $25,000? Well, it gets some of it gets billed to the patient, or gets billed to the patient, or written off. Okay? Now, this patient is seen in the hospital, let's just say 5 times a year. 5 times a year. And so 5 times 15 is what? It's like 75,000 for the year, right? Mm-hmm. So 75K for 2019. Okay. Now they paying out. They saying, golly, we paying out a lot of money for this patient. I mean, and they're chronic. Do you know what I mean by chronic? What do I mean by chronic? What do I mean by acute? Chronic is that they are here all the time. They're going to forever have this problem. It's not a problem that's going to go away. It's not a problem that's like a flu or a cold or a sinus infection. It's not acute like that. It's chronic because it's there and it's existing, and they have to do all that they can. Oh, hold on just a minute. I'm sorry. This is my husband. I gotta see what he wants right quick. I'm sorry. Hey, babe, what's up?
Go to the $2 movie theater.
Okay.
The $3.45 movie theater.
Okay, babe, have fun, all right?
I'm going to see the Genie movie with Will Smith.
Oh, you'll like it. I loved it.
Okay, thank you, Mookie.
All right, I'll holler at you later.
All right, thank you, Mookie.
Bye, baby. Okay.
Acute and chronic.
Acute and chronic. Thank you. When it's chronic, they're going to be treated like that all the time. Maybe they may not come to the hospital 5 times this year. They may come 5 times next year and 3 times this year. But we all know it's going to be around that issue because why? Their immune system is some fashion going to get compromised. So they got to deal with that. Does that make sense?
Mm-hmm.
Okay. So what the DRG says, we're going to make some compromise here because we see a trend. And the trend says that the patient comes into the hospital 5 times.
Mm-hmm.
So for next year, we're going to line them up on a DRG. So instead of us paying $75,000, we need to, get some adjustments, get some a fair payout, And so the United States Treasury don't go broke and pay $50K for that year. That's what a DRG does. It gives weight to the illness of how much, and based on a 4-day stay, how much a patient or how much the insurance company are going to be liable for. Okay, it helps save money for the insurance company. It helps save money for the patient. It helps save money for the government. Okay, this is just going to be a bless his heart or bless her heart, a sicky patient for the rest of their life. Same thing with diabetes, strokes, and CHF. Does that make sense? Okay, so let's bring it all together now. Let's bring it all together. Page 3 in the AAPC book. So inpatient coding focuses on different subset of skills where coders will work on ICD-CM and ICD-10-PS. Coders will also assign medical severity diagnosis related groupings. These are severe illnesses. They're chronic. Okay? All right. Regardless of the setting, codes, update, and insurance payment policies may change as often as quarterly. Okay? Coders require continuing education to stay abreast of the changes. Okay? Now, let me talk about continuing education for a minute. Based on your certification. Can we talk about that for a minute? Okay, so if you're getting your CPC, and your CPC may require 14 continuing education units a year. That means, let's say that you get your certification as of November 1st, 2019. Yay! You have until November 1st, 2020 to get your 14 hours. Your 14 CEUs. I promise I'll give you some more. Your 14 CEUs. Does everybody see that? I know that's real faint. Okay. Your 14 CEUs. So that means it takes 12 months in a year. You may have to work on 1 to 2 CEU courses. And those courses can be for free. Everything don't have to cost you money. Put it on here so y'all can see it. You can go to Texas Healthy Step. I want you, when you get a chance, to create an account on Texas Healthy Step. Texas Healthy Step. You can go on CMS and see if they got some continuing education courses. You can also go to AAPC and just do some, you know what I'm trying to say, PC. Get some continuing education courses. You can also, and some folks like to use what they call Medscape. I'm not a huge Medscape fan, but it'll do. Medscape give like 0.5, 0.25. If you're a person that needs to get a whole 1 point, that means if you go use Medscape's continuing education units, and I have nothing against Medscape, let me say that. Don't call and sue me. Don't call and fuss at me. Don't even call and question me. I just said I have no problem with Medscape, okay? Let me make myself real clear with that, okay? Now, if you're going to get 1 whole point with Medscape and each video that you watch is 0.25, that means you got to watch 4 videos to get 1 point. Mm-hmm. If you watch a video and it's 0.5, 50, that means you got to watch 2 videos to get 1 point. Okay? Texas Healthy Step, sometimes they give, well, most of the times, and I use them a lot. I like them. They reading and stuff is rather lengthy, but it's worth it. You'll get 1.5, 2 CEUs, and you get stuff done a lot quicker.
CMS is good.
Yes, CMS is good too. You get a lot more. Now, that's for the freebies. Okay? Now, sometimes your job may send you to a seminar, or if they say, I need you to go to this meeting is going to talk about the latest thing on surgery for laser, eye laser surgery, because of where you work at, eye laser surgery. Okay. The first thing you need to ask is, okay, yeah, I would love to go, and I'll go regardless. But my question is, are they going to give me a certificate of completion? And if they say yes, okay, will it have the credit hours on there to say I was here for a certain time? Sometimes, it depends on if they contract with a company or whatever. They may give 2 or 3 or 4 credit hours. If it's a 4-hour meeting, then it's 4 CEUs. If it's a 3-hour meeting, then it's 3 CEUs. You see how that works? Okay. Then make sure that they put that on there. So when you do turn it in to AAPC, you may have to turn in like, I don't know, maybe 6 or 7 documents that add up to 14. You understand what I'm saying? Or maybe 15, 16 documents, but it all adds up to 14 CEUs. Does that make sense? Then you could do that. But now let's just suppose your job said, well, why do you need that? They're not going to give out one. Well, it would help on my recertification credit education units. So when I have to update, and you don't take a test over, let me say that. Once you take the test, that is it. All they require, and it's the same thing for HEMA, NCCT, NHP, NAHP, NHA, all those, they once you take the license and the certification, be it RHIA, RHIT, once you take that, you are not required to take the test over again. The only way you take the test over again is if you let your certification, no, not just expire, but if it lapse. And if it lapsed, like it expired November 1st this year, and you never recertified for it, and now it's the year 2024. It's 5 years later now. You may have to redo the test. You see what I'm saying? So always, if you get in a pinch or a bind, life does happen. It's real. Finances are real. Hey, I've lived it. And you in a pinch, just say, well, what is the time lapse that I have Because I know I'm not going to get my CEUs done on time to recertify this. What is the, if they say if you can get it done within the year, then we'll go ahead and backdate and certify you. Does that make sense?
Yeah.
But if you go longer than the time lapse and you have to ask them specification and get it in writing, then you're going to be okay. But if it's 5 and 10 years later, you got to redo that test, sweetie. That's a pain. Oh my God, it's a pain. Okay? This, now, some webinars you go to may cost you $125. May cost you $200. And it's going to talk about coding. It's going to talk about diseases. It's going to talk about a lot of stuff. And it may include lunch and all this here stuff. Your company may pay for it, or you may have to come out of pocket for it because you hunting down for CEUs. Okay? So a lot of times those type of seminars or webinars, they give 5 or 6 CEUs because you paying for that.
Yeah.
Does that make sense? You're paying for that. So I just had to speak a little caveat there for a minute because a lot of folks get nervous. I gotta redo the test. No, you don't. No, you don't. No, you don't. No, you don't.
I just got recertified with the NCCT, and I turned in my class for the coding, and so they certified me right away because it was
Good.
like 170 hour.
Yeah.
So it's like I just need 14.
Okay.
Wait.
Good. So how much you paid?
The NCCT for the billing is $70
Yeah.
to renew,
Yeah.
but then the CEU you have to do it your own.
Yeah.
Like sometimes you have to pay if you want a class like for credit, but if not, there's free on
Yeah.
the website.
Just know if you get the free ones, it's gonna take you a minute.
So I'm doing the coding,
Uh-huh.
and I'm in the coding, so it's not free. It's the class I'm taking.
Yeah. Okay. So
Yeah.
it's not free.
Yeah.
The class you're taking.
Yes, for the coding class. So
Okay.
I'm using that credit for my
Oh,
NCCT.
very
So,
good. Very good. You can.
Yeah.
If you're going to school to update yourself, you can use your classes towards your CEUs.
Yes.
Very good. That's
Yes.
yeah, that needed to
But
be
it
said.
has to be related to medical.
That's right. That's right.
You can't not do it with science, or they don't accept
It all has to be medical related. That's
medical
right.
related.
Thank you, Twee. The hierarchy of providers. A variety of medical providers, staff physician offices, and hospitals, including physicians and mid-level providers, also known as physician extenders, such as physician assistants and nurse practitioners. Mid-level providers often reimburse at a lower rate than physicians and require a physician's oversight. Okay, those are your nurse practitioners and your physician assistants. Different providers have different levels of education, and each state has a scope of practice guidelines for various provider levels. Check your state board's website for scope of practice information. Now, you have different types of payers. Let's look at that. Although some patients will pay in full for their own medical expenses, most patients will have some type of insurance coverage. There are 2 primary insurance users: commercial and governmental. I just said it. It's right here on page 3 of your AAPC study guide. Okay? I just said it. All right. Commercial carriers are private payers that may offer both group and individual plans.